So we're going to continue with the last part of the NICU, and this is part 7. Let's discuss cold stress and hypoxia. Hypoxia, IVH, hypoglycemia impair the baby's ability to burn brown fat to actually stay warm. Cold stress sets up chain of physiologic events such as hypoglycemia, pulmonary vasoconstriction, hyperbilirubinemia, respiratory distress, and metabolic acidosis. So let's think about cold stress. You have the release of norepinephrine to stimulate brown fat metabolism at the same time that you have decreased surfactant production and increased anaerobic metabolism and increased metabolic rate. So as you're going down through, let's talk about the release of norepinephrine. You run into pulmonary vasoconstriction, which causes a decreased blood flow through the lungs, which leads to hypoxemia, and acidemia, which goes back to pulmonary vasoconstriction and so forth. Looking at the decreased surfactant production, that leads to atelectasis and a decreased oxygenation, which leads to hypoxemia and acidemia. Looking at the increased anaerobic metabolism, that runs into an increased non-esterified fatty acids, which leads to hyperbilirubinemia. With the increased metabolic rate, you have the increased oxygen consumption, which leads to an increased utilization of the glucose, which leads to the hypoglycemia. So when you look at hypoglycemia, that is a plasma glucose concentration at or below 40 milligrams per deciliter. Values are less than 20 to 25 need a D10W bolus immediately. Most common metabolic disorders in IDMs, SGA infants, preterms, and AGA infants. Symptoms are lethargy, limp, jitteriness, tremors, jerky, seizures, pallor, cyanosis, poor feeding, poor sucking, vomiting, irregular respirations, RDS, apnea, high-pitched or weak cry, exaggerated Moro reflex. Hypocalcemia may be a concern when the baby is hypoglycemic. You want to monitor at-risk infants and use infant's lateral heel as a preferred site. Okay, so let's take a look at pathologic jaundice. It's usually caused by ABO or RH incompatibility. Jaundice may be present at birth. Erythroblastosis fetalis, mom is Rh negative, baby is Rh positive, mom's antibodies enter the fetal circulation and they start destroying the fetal red blood cells. The baby responds by making more red blood cells, and then we have the invention of the ROGAM has greatly actually curbed this process by, the mother getting the injection of the ROGAM. Any mother who is Rh negative or from blood type family O are at risk. Because of the ABO incompatibility, you have that the fetal system will respond if the mother is blood type O, the infant is blood type A or B. It could result in jaundice. It's rarely severe enough to be clinically diagnosed as hemolytic disease and or treated. Less severe than the Rh incompatibility. So the danger of jaundice, you have untreated hyperbilirubinemia, and that's due to either type of jaundice, can result in kernicterus or acute bilirubin encephalopathy. Kernicterus, bili deposits in the basal ganglia of the brain. Outcome is profound neurological damage. They must get treatment. So what is the actual treatment for jaundice? Well, we have to monitor serum bilirubin. Phototherapy. You can have more than one light source. Lights facilitate the excretion of the unconjugated bilirubin. It helps change it from the non-water soluble form to the water soluble form that is excreted via urine and bile. They may have to have blood exchange transfusion. They may have to have infusion of albumin. And what you want to do is monitor for complications of kernicterus. So let's talk a little bit about what your nursing responsibilities are in phototherapy. Well, you have to expose the newborn to a maximum amount of skin service for optimal therapeutic results. And then the phototherapy is measured every 12 hours with the daily serum bilirubin levels. You want to be sure to turn the lights off while the blood is drawn. You also want to be sure to apply eye patches while phototherapy is in progress. Eye patches removed at least once per shift. You want to assess the eyes for signs and symptoms of conjunctivitis every 8 hours, and you want to allow eye contact during feeding. This is for social stimulation. You want to make sure that you're frequently monitoring the temperature. You need to encourage that the infant gets breast milk or provide formula frequently to assist in the excretion of bilirubin. Be sure that the infant is repositioned at least every 2 hours. You want to keep the parents informed and encourage holding and caring for the infant while undergoing phototherapy. You want to assess the newborn skin, such as check color for jaundice, see if they're bronzing, or whether they're developing pressure areas. So we have two images here. We have the infant Billy glasses and the infant Billy mattress. Let's look at a few guidelines for phototherapy in hospitalized infants. If to the left here, you'll see that there is a chart. It shows total serum bilirubin levels based upon, the age, birth, 24 hours, 48 hours. You want to use total bilirubin. Do not subtract direct reacting or conjugated bilirubin. The risk factors could be isoimmune hemolytic disease, G6PD deficiency, asphyxia, significant lethargy, temperature instability, sepsis, acidosis, or the albumin is less than 3.0 grams per deciliter if it's measured. For well infants, 35 to 37 weeks can adjust the TSB levels for intervention around the medium risk line. It's an option to intervene at lower TSB levels for infants that are closer to 35 weeks and at higher TSB levels for those closer to 37 weeks. It's an option to provide conventional phototherapy in a hospital or at home at TSB levels 2 to 3 milligrams per deciliter. Below those shown, but home phototherapy should not be used in any infant that has risk factors. So for some of the teaching highlights that you're going to provide instructional checklist for in-room therapy is explain and demonstrate the placement of the eye patches and explain that they must be in place when the infant is under the lights. Explain the clothing to be worn. It's usually just diaper under lights and then dress and wrap when they are away from the lights. Explain the importance of taking the infant's temperature regularly. Explain the importance of adequate fluid intake. Explain the charting flow sheet. Explain how to position the lights at a proper distance. And explain the need to keep the infant under the phototherapy except during feeding and diaper change. Your charting flow sheet usually will include your intake, your output, and how long the eyes had been covered. So let's take a quick look at the anemia in the newborn. This can be resulted from prenatal blood loss, birth trauma, infections, or blood group incompatibility. We have the excessive hemolytic of red blood cells that usually result of blood incompatibilities. Then you have the physiologic anemia of infancy, gradual drop in hemoglobin over the first 6 months of life. It's usually self-correcting. Okay, so for the assessment, you want to assess for signs of anemia. You're going to look for pallor. You want to record the total amount of blood drawn for all laboratory tests. If the blood loss is acute, baby may show signs of shock, and these include capillary filling time greater than 3 seconds, decreased pulse, tachycardia, and low blood pressure. Okay, moving along to polycythemia. With polycythemia, we have a blood volume and hematocrit values that are increased. Generally, the central venous hematocrit is greater than 65%. It is more common in intrauterine growth restriction and full-term infants. It's usually due to delayed cord clamping, maternal fetal and twin-to-twin transfusions, and chronic intrauterine hypoxia, such as the moms that smoke during pregnancy. So we're looking at the venous hemoglobin level greater than 22 grams per deciliter. So during the nursing assessment, you're going to assess for, record, and report symptoms of polycythemia. Many infants are asymptomatic, but as symptoms develop, they are related to, the poor perfusion, such as hyperviscosity of blood, impaired perfusion to capillary vessels, and treatment is indicated if symptomatic. They'll have partial exchanges done. Partial exchange is blood taken out and replaced with fresh frozen plasma, albumin, or saline. So let's look at some of the polycythemia symptoms again. We talked about tachycardia, CHF from increased blood volume. RDS, such as grunting, tachypnea, cyanosis, and hypoxia. Hyperbilirubinemia. Feeding intolerance, poor feeding, vomiting, necrotizing colitis, hypoglycemia, hypocalcemia. Decreased urine output, hematuria, proteinuria, and renal tubular damage. Then we have jitteriness, irritability, decreased activity or tone, lethargy, stroke, and/or seizures. Let's talk a little bit about sepsis and the signs in a newborn of sepsis. They could have subtle behavior changes, such as the infant per se not doing well. They can have lethargy or irritability. They may have color changes, like they may appear pallor or duskiness or cyanotic. The infant may have a shocky appearance. They could have cool, clammy skin. They may be experiencing hypothermia or temperature instability. They may have signs and symptoms of hyperbilirubinemia. They may be experiencing tachycardia, bradycardia, or have apneic spells. They could have feeding intolerance, a decrease in total intake, abdominal distension, vomiting, poor sucking, lack of interest in feeding, or even diarrhea. Sources of infection can be through vents, umbilical lines, PICC lines, ET tube. In NICU, nosocomial infections present as bacteremia, UTIs, meningitis, pneumonia, or maternal conditions may cause infection in the baby. So what do we want to do if we suspect sepsis? We're going to get a CBC, a CRP, a blood culture, a TA, a respiratory viral panel, an HSV swab. We're going to do a chest and or abdominal x-ray. So parents will experience difficulties in the NICU. We want to facilitate parental adjustment to the infant's special needs. Parental reactions can include, but aren't excluded to, acute feelings of grief, feelings of guilt and failure, postpartum depression, loss of control, feeling out of the loop, and they can grow to resent the NICU sometimes because of this. They can have, experience guilt when they're at the hospital because maybe they have, obligations at home or even more children at home and they feel like they're neglecting them. Or they may even have guilt when they're at home feeling like that they're neglecting the baby that's in the NICU. They will struggle to work and care for their baby. Families sometimes grieve the loss of that perfect birth that they had planned for. If the baby is really early, sometimes the parents don't visit much in the first few days until they are reassured that the baby is going to actually survive. NICU moms do a lot of blaming themselves, place a lot of guilt on themselves for the NICU admission. They may be angry towards others and resent those who have a baby and go home in a few days. They may have postpartum depression. This is a major risk. Parents struggle to cope with how to be at the NICU and be at home with other kids. Should they go back to work and save their time for when the baby comes home? How are they going to pay for the astronomical cost of the NICU? Best thing to do is involve the parents in the baby's care as much as possible. Baby isn't going home with you, so it's time to start teaching the parents how to care for their own baby. Be a good listener and reassure the mom that she isn't being punished and didn't do anything wrong. Allow siblings to visit per policy. Encourage families to talk to other NICU families for support because your fellow NICU families know exactly what they are going through. This concludes all the NICU lessons. If you have any questions related to course content, contact the instructor.